Right now, it's my pleasure to introduce our next topic, which has been requested by many of you. Iron deficient anemia. It can be a challenge for many women with bleeding disorders. And here to moderate this session and introduce our presenters is Dr. Jill Johnsen, who has been part of this conference from the very beginning. Before we ever launched the first one, she was one of our docs behind the scenes helping us get things coordinated and figure out what the best topics were. She's an associate member of Bloodworks Northwest Research Institute and associate professor at the Department of Medicine at University of Washington. So Jill, welcome.
Oh, thank you, Sherry. Hi, everybody. It's a real pleasure to be here for this session. My role is just to remember to help introduce everyone and keep things moving along on this really interesting topic. Our first speaker today is Dr. Alan Mast. One of the many things he's expert in is how iron works in our bodies and how iron deficiency happens. So he's going to talk today about some of his work and his knowledge to share with you on how iron deficiency happens and what we know, and probably some of what we don't know. We are going to then be having Jim Munn after that, and then we have a question and answer session at the end. So please feel free to put your questions into the chat. Remember that we're not able to give individual medical advice or talk to anyone's specific case, but if you have a question that you are thinking of, someone else is probably thinking of it too, and we'd love to have a brisk discussion at the end. So with that, I would like to welcome Dr. Alan Mast, who's at Versity, and who is a pathologist and also basic science researcher in hemostasis and also in transfusion medicine. So Dr. Mast.
All right.
I think, Alan, you're trying to do your slides. So I'm going to say
right.
to our technical support, can we give a hand getting, there we go. Thanks, okay. Dr. Mast, for being patient.
Okay, so my slides are working. Okay. So I just want to thank everyone for coming and listening to my presentation. I will be talking about iron deficiency and iron deficiency anemia, and hopefully one of the things you'll learn is they're not exactly the same thing, and I'll try and help teach you about the differences between the two different aspects of iron deficiency and iron deficiency anemia. I am an employee of Versity, which is a blood collection organization that is in Illinois and Wisconsin and Indiana, Michigan, and Ohio. And I have to say at the beginning of these things that what I'm going to say in this presentation are my opinions, and they're not necessarily the opinions of Versity. Okay. So I wanted to start off just by discussing why iron deficiency is bad, why it's something to be avoided, and I hope I can convince you of that. So here are some just common causes, things that happen with when you're iron deficient. Fatigue is one of the most common side effects of iron deficiency. We all get fatigued. At least I do, late in the evening and when you go to bed, but this is different. People get more fatigued and are not able to do regular tasks, or just are more tired doing regular tasks. There's also something called restless leg syndrome, which is where people will get these creepy crawly feelings in their legs, particularly at night when they're trying to sleep, and it can cause sleeplessness and restlessness, and that's associated with iron deficiency as well. More serious, other kinds of things is you can have delayed development of unborn babies. A baby's brain development takes a lot of iron. We'll talk more about that, as well as continued brain development through childhood takes iron as well. But this is a reason why pregnant women, you don't want to have iron deficiency during pregnancy. There's also this condition called pica, this is a picture of someone who's going to take Comet Cleanser and put it in their mouth and chew it. And this really happens. There's people that will chew unusual substances. And I know I had a person that worked with me. She was a clinical coordinator on one of our studies. And she said, yeah, my mom chewed Comet Cleanser. And she remembered in her childhood growing up that her dad was always trying to hide the cleanser from her mom, so she wouldn't chew it. And obviously, this isn't a good thing. It's a side effect of iron deficiency. And it happens in about 1 to 2, and now I'd say 2 to 5% of people with iron deficiency can have pica symptoms. And most commonly, this is people chew ice. Sometimes they'll chew unusual substances like Comet, but most commonly it's ice, and it's not uncommon to see this. And I just wanted to show this picture. This is a picture of the desk of another person that worked with me on clinical studies, and you can see she has 1, 2, 3, 4, 5 cups on her desk. And the reason she has these cups is she would take them all to an ice machine that had good ice, those nice crunchy ice that she could easily chew. There's actually several buildings away from where her office is here, and fill them up with ice and bring them back to her desk and then chew ice. And so this is a common thing that you'll see. We also had another person that worked in our research institute, and she'd bring in a bag of like those dumbbell lollipops or whatever that you get like if you go to the bank, and she'd chew lollipops all day, every day, and she'd chew a whole bag of them every day. And so this is just recognizing, if you watch around, there might be some people on this call that have these kind of or on this meeting that have this kind of symptoms. And once I've noticed this, I've seen people that have it. So it's not that uncommon, and it's almost always a consequence of iron deficiency. And that means that if you treat the iron deficiency in the people that have these symptoms, the pica behaviors will go away. So I wanted to share this slide as well to just show, I mentioned that unborn babies need iron to develop their brain, but so do children. It happens all the way into their young adulthood. So what you can see on this picture is just their images of the developing brain, and over time periods. This is like from children that are age 5, and these are adults that are age 20. And you can see that the yellow and green and red areas are the immature areas, and then as they mature, that becomes more and more blue. But what's important to notice is that here, even when they're near teenagers, you can see there's still red and blue areas, and particularly a red area right here that remains into the early 20s. And this is the area that has to develop properly. I mean, when it doesn't develop properly, you get diseases like schizophrenia, and these this brain development is all very dependent on iron to happen. And the next slide, I'll share you some quotes from the person who published these 2 papers. So his name was Paul Thompson, and he said, healthy brain wiring in adults depends on having good iron levels during your teenage years. And this connection is stronger than we expected, especially as we're looking at healthy people, at people who are young and healthy. So the studies didn't look at sick children or sick teenagers or sick young adults. They were just regular young adults, and they could see that they were, their brains are still developing, and that iron was needed for this brain development. And because you would not think that iron in our diet would affect the brain so much in our teen years, but turns out that it matters very much. And finally, he said, iron is critical. Iron is vital for making myelin. Poor iron levels in childhood erode your brain reserves, which you need later in life to protect you against aging and Alzheimer's. So sort of with that introduction, I hope I have perked your interest to recognize that we want to avoid iron deficiency. And it's, as you all probably know, iron deficiency is much more common in women than it is in men, because women have menstrual periods and they have babies, both of which use lots of iron. So what I now want to do is, since I work for a blood collection organization, I want to try and talk to you about the studies we've done using blood donors as a patient population, and try to, I recognize this is not the same as bleeding disorders and women with bleeding disorders, but I'm going to hopefully convince you that it's somewhat similar. So one of the things that we can look at blood collections, you can look at it as just a large clinical study. I mean, we're collecting the blood to treat patients in the hospital, but you can also look at the donors and what we're doing to them as a clinical study. And we have about 40,000 people donate blood in the United States every day, and they can be range in age from 16-year-old girls or boys to people over 80 and even 90-year-old people will come in and donate blood. And this picture here is a picture from a high school blood drive where this is a 16 or 17-year-old girl who's donating blood. And it's one of the things that I'm somewhat concerned about because these young girls are already stressed for iron, and then we're having them donate blood as well, and I'll show you what happens. And so you can get people from all races who will come in and donate blood. And the really advantage too is they already have a needle in their arm and they're very willing to participate in clinical studies. So it's very easy to get blood samples, a small sample from these blood donors to do clinical studies on. And so, you know, a question that I've always been asking, or for many years I've been asking, is what can we learn about anemia and iron metabolism from blood donors? And so I want to teach you a little bit more about what a blood donation is. It's an acute hemorrhage. So in about 10 minutes, you're having about 525 mils of blood removed from the blood donor. And in comparison, a heavy menstrual bleeding is defined as greater than 80 milliliters of blood. So I think this is pretty similar. I'm sure there's women with heavy menstrual bleeding that lose more than 80 mils of blood per menstrual cycle, but a blood donation is certainly if you have lots of them, it's going to be similar to having heavy menstrual bleeding. And if you calculate it out, females on average lose 12% of their blood. The smaller the female is, the higher percentage this will be. And there's certainly, if you can calculate, there's like 15 to 17% of the blood, especially some of these younger, smaller teenage girls that donate blood, will be losing more than 12% of their blood. On average, males lose 8% of their blood just because they're larger than females on average. And the thing that happens, we allow blood donors to donate every 56 days. So that's every 8 weeks or approximately every 2 months. And the only thing we screen for in regards to your qualification physiologically, I mean, from an anemia point of view, is that we make sure your hemoglobin is greater than 12.5 grams per deciliter, or greater than 13 grams per deciliter if you're a male. And that's not super high. That's at the lower end of the normal reference interval for hemoglobin in males and females. And importantly, we don't do any tests for iron status. So one thing I want to teach everyone about is that even though if you get iron deficiency, you will get anemia. And anemia is really a lack of hemoglobin or not enough hemoglobin in your blood. But you can also have iron deficiency and still have adequate hemoglobin in your blood. And so without having anemia, you can still have iron deficiency, and you can still have a lot of those side effects that I talked about earlier in the presentation, even though you don't have anemia. So this is just I'm going to show you a graph of the impact of what a blood donation does for iron stores. So the y-axis of this graph is how many milligrams of iron are a typical male. And a typical male has about 1,000 milligrams of iron, and they're stored in their body. So this is iron that's available to be used for for making new red blood cells. And females have much less, only about 250 milligrams. And this is because females lose blood from menstruation and pregnancy. And one blood donation removes between 200 and 250 milligrams of iron. So just one blood donation can take away all of a female's iron stores in their body. And this is all averages. There certainly are females that will come in and try and donate blood and have very much lower iron stores than this. And as a consequence of this, female blood donors, especially ones that donate frequently, have iron deficiency. And we did a study on this, and among female donors who donated more than 2 times per year, there was iron deficiency in 66% of them. So 2/3 of them had iron deficiency. And we have another measure of severe iron deficiency, and over a quarter of them had severe iron deficiency. And just to teach everyone a little bit, there's a test called the ferritin test, and that's the best single test that you can use, especially in an otherwise healthy person, for measuring how much iron stores are inside of you. So if you wonder if you're iron deficient and you go to your doctor, you want to ask to have a ferritin test performed. And that was the main test that was used to determine how severe the iron deficiency was done in these female blood donors. And in males, it's not as severe because males have much higher iron stores to start out with. But still, about half of them had iron deficiency and 16% of them had severe iron deficiency. So I hope I've at least convinced you that iron deficiency is present in blood donors. It's not exactly the same as women with bleeding disorders, but I think I hope you'll agree with me. I think you can draw some analogies. So what I want to do now is teach you about some of the studies that we've done with blood donors to try to mitigate iron deficiency in blood donors. And I think these principles, or some of the things we've learned from these studies, will also apply to women with bleeding disorders. So one thing we've learned very clearly is simply encouraging blood donors to eat an iron-rich diet does not prevent iron deficiency. And these are studies. We did a large study of over 2,000 blood donors and gave them like this 7-page survey of their dietary preferences. And the only thing that came up as positive for preventing iron deficiency was the donors who said they ate clams more than 3 times per week. And obviously this is not true. It's just because we ask so many questions, something will come up as significant. If you ask enough, anytime you do research and you ask enough questions, you have a chance of something coming up as a false positive. And this detailed study we did, this was the only thing that came up as positive. So there was no common thing that blood donors described as what they were eating to prevent iron deficiency. Yes, and again, this is on an average of lots of blood donors. I'm not trying to say that there can't be a single or individual blood donors who ate incredibly iron-rich diets, and it did have an effect. But in general, people don't eat those iron-rich diets, even when they're told to do so. You know, we try and educate them, and it still doesn't work. So what does work are the following 2 things. Providing people with oral iron supplements. And oral iron supplements can either be given as like a multiple vitamin with iron, or you can just take plain iron pills. And you can get any of these at your local drugstore. And usually if you have to look at the bottle of the multiple vitamin and make sure you're getting a multivitamin with iron. And you can look on the bottle, and it usually will say it's like 18 or 19 milligrams of iron. And that's always elemental iron. And so just to teach you, importantly, there's what I'll talk about in this talk is elemental iron, and that's the actual amount of iron that's in a pill. There's also other things that are in a pill that are not iron. And so if you buy like a pill of iron sulfate, it will say it's a 325 milligram pill, but it's not 325 milligrams of iron. There's also the sulfate in there. And so most of those iron sulfate pills only have 60 milligrams of iron, and the rest of it's the sulfate. So you have to pay attention to what the milligrams of iron is in any pill that you look at. And as I just said, so multivitamins iron typically will have 18 or 19 milligrams of iron. I know this because I've gone to the store and just looked at them. And then the other thing that works for a blood donor, obviously, is just to not donate as frequently, because then they're not losing that big bolus of iron every time they donate blood. So we did this a large randomized study, which we called the STRIDE study, or Strategies to Reduce Iron Deficiency. And what we did a 2-year study of almost 700 frequent blood donors. So these were blood donors that had donated frequently and were likely to be iron deficient, as I described earlier. We did all these tests to measure for different types of iron deficiency, which I'm not going to go into, but we each one of these tests is for this talk. And then we randomized people to different pill arms, and we gave them 38 milligrams of elemental iron, and they're supposed to take it for 60 days after every donation. 19 milligrams of elemental iron for 60 days, or we gave them a placebo or a dummy pill for 60 days that had no iron in it. And then we also had a letter arm where we wanted to see if we could influence blood donors to act on their own without us sending them a pill. And so some of the blood donors got a letter saying, you have iron deficiency. We recommend that you either take this iron pill or a multiple vitamin with iron or delay your next donation. So we gave them advice by a letter. And then we had another control group where we just said, thank you so much for donating. We didn't tell them if they were iron deficient or not. And so this graph shows what happens, and it's at the beginning and end of the study. So on the left side is baseline, and the right side is final 2 years later. So, and what you can see, and this is how their ferritin changed, which is the best marker for iron stores in the blood donor or in anyone. And you can see that these, if they took 38 milligrams of iron, 19 milligrams of iron, or got the letter with information, they all improved their ferritin a lot, and it was approximately equal on this graph. Whereas the control groups where we gave them the letter with no information or the pill without iron, it didn't have any effect on their ferritin levels. And so to me, this is a really important finding from this study. Oh, whoops, I can't say that. Also, we carefully track side effects from reported from any of the blood donors, and there was no difference in reported side effects of the placebo group, the 19 milligram group, or the 38 milligram group of iron pills. And obviously, we didn't track side effects in the people that just got a letter. But what was interesting was how close the responses between the 19 milligrams of iron and the 38 milligrams of iron were in the two groups. And we did an additional study to characterize this in more detail. And every way that we looked at it, the 19 milligrams was equally effective as the 38 milligrams. So to me, this is really important because it just showed that if we can convince blood donors just to take a multiple vitamin with iron for 60 days after they donate, it will do a lot to help prevent their iron deficiency. And having them take more iron wasn't helpful. And one of the reasons that's important is because as you take more and more iron, people will start getting side effects, particularly with their gastrointestinal tract. They'll get diarrhea or they'll get constipated, and they won't want to take iron anymore. And a lot of times, much higher doses of iron are diagnosed or prescribed for people to treat their iron deficiency. And this study seemed to show that, in blood donors at least, which I think I showed you do have severe iron deficiency, 19 milligrams a day was plenty. It was as good as 38 to treat the iron deficiency. So I'm going to go on and say a few more things about iron deficiency. One of the advantages that I have is I participate in this program sponsored by the National Heart, Lung, and Blood Institute called the RED3 program, and we've done a lot of studies of iron and blood donors through this program. And here you can see where they're located in Connecticut and Pittsburgh, and then Wisconsin and San Francisco. And we were really interested in teenage iron deficiency, and so we did a study on high school blood donors. And this is just a picture of a girl and you can ask whether she's an adult or a child, and I think a lot of people say, well, she still looks a little bit like a child in this picture, and yet we still put a needle in her arm and take 525 milliliters of blood out of her. And so a lot of us were concerned about this, and we wanted to do a study just to show what's happening with teenagers. And the reason we know teenagers have increased iron need, they're continuing to grow physically. They have recent onset of menses for girls, and they're trying to adjust to that physiological change. And a lot of times they won't have the best dietary habits. And this graph just shows what we did is we just tracked how iron deficient teenagers versus adults became as they donated blood over multiple times over 2 years. So what the x-axis of this graph shows is just the number of donations that they had in the previous 2 years. And the blue bars show the prevalence of iron deficiency in adults, and the red bars show the prevalence of iron deficiency in teenagers. And what you can see is the red bars are going up a lot faster than the blue bars are. And it just is consistent with us showing that teenagers are more susceptible to iron deficiency than adults. And when you combine these data back with where I showed that their brains are still developing, that we can't ignore iron deficiency in teenagers. And so that's why I took this personally to my family, my daughter, when she started menstruating. I taught her about, said, you need to start taking multivitamins with iron. I showed her this stuff, and she's pretty good about it. And she's now in her 20s, and she's still taking a multivitamin with iron every day. And so, anyhow, so that's just what I did for my daughter. And we did one other study. This is getting a little more detailed into what happens to blood donors, but it has one important point that I want to point out. And so we did this other study called the Hemoglobin Iron Recovery Study, and we had 215 participants, and they gave 1 unit of blood, and then we didn't let them donate again. And we followed them with periodic sampling over the next 24 weeks, which is 6 months. And we selected these donors to half of them have low iron and half of them not have low iron when they were enrolled in the study. And the responses were somewhat different. And then we either gave them an iron pill. In this case, we gave them 38 milligrams of iron, or they just didn't get any pill at all. And so this is a graph that shows the ferritin again, and over the time since they donated blood. You can see that right after they donate blood, their iron levels drop a lot because they just lost a whole bunch of iron from donating blood. And then if they took an iron pill, it would recover relatively rapidly and go past even where they started. This green line just shows where 26 nanograms per milliferritin is, which is one measure of iron deficiency. And so if you take these other iron replete donors and don't give them iron, you can see that they become more iron deficient and they stay iron deficient for longer, and then they start recover after about 100 days. But it's much longer than this. Is the 56-day mark where donors are allowed to repeat and donate again. And you can see that if we took someone in this group and had them donate blood again, they haven't recovered at all, and they're just going to keep dropping and dropping and becoming more and more iron deficient. This is what happened to patients with iron deficiency that we gave iron. They responded to the iron quickly and started to absorb it. And the patients or the blood donors that had low iron at first and we didn't give iron, they didn't get any better. They stayed iron deficient. But one of the things I'm showing this graph for is right here is that if you look after about 100 days, 80 to 100 days, the slope of this line is the same as the slope of this line. And so what it's meaning is that the biggest effects of iron supplements are in the early periods after the blood donation occurred. So there's a stimulus from just the loss of blood that tells your body to absorb more iron, because your body knows it's going to need the iron to make new red blood cells. So this is just to sort of summarize my thoughts about iron deficiency from treatments of blood donor studies, and hopefully maybe it might help some of you too as well when you're thinking about the prevalence of possibility that you might have iron deficiency. So from our studies, it seems that a multiple vitamin with iron, just containing about 18 or 19 milligrams of elemental iron, may work as well as higher doses of iron big advantage is it doesn't have side effects. Absorption is best of iron is best when you're bleeding immediately following bleeding. So that's what I just showed you from the blood donor. If you wait too long, and it seems to lose the effect of the iron absorption. And then just recommending an iron-rich diet or trying to eat an iron-rich diet probably does not work very well. And certainly taking an oral iron pill, I think, is a much better way to go for trying to prevent and treat iron deficiency. So with that, that's all of my slides, and I'll stop there.
Hi, everyone. My name is Jim Munn, and I'm a program nurse coordinator at the University of Michigan Medicine's Treatment Center, and I'm happy to follow Dr. Mast today. And thank you, Jill, for the introduction, and to the team here for allowing me to speak today. I'm going to be talking about iron deficiency anemia and some of the treatment approaches that we utilize in the treatment center. Next slide. So just as Dr. Mast had mentioned, when you come to the office and you're telling us you're fatigued, you've got your cup of ice and you're eating that, we notice that you look a little pale. Maybe you're also having some weakness, headaches, things like that. We're probably going to draw labs to check for iron deficiency. So from there, what we would do is order simple tests here. There's more. I think Dr. Mast had mentioned a couple more that they used in their studies, but for us, we'd simply start with what you see on the screen here, a CBC, iron, the total iron binding capacity, the percent transferrin saturation, ferritin levels, and also our reticulocyte count. And one thing that we always want to do is when you are on oral iron therapy is to tell you, please do not take your iron on the day when you're going to get your labs drawn, because they can falsely elevate the responses to that. Next slide. So there are a lot of food sources of iron, and you see them here. The recommended daily iron intake is anywhere from 7 to 18 milligrams or higher if you're pregnant, up to 27 milligrams a day. And there are two forms that iron take. The first one is called heme iron, which is from animal sources. Essentially, you'll find these in the lean red meats, fish, dark meat from poultry, the organ meats, shellfish, like the clams that Dr. Mast had mentioned, and then non-heme iron, which is from plant sources, often grains, nuts, vegetables, fruits. And then you can get them from also beans and fortified foods. One of the biggest ones being, for instance, cereal. That is fortified a lot with iron nowadays. And between the two, heme iron seems to be more readily absorbed in the body than does the non-heme iron. Next slide. So there are pieces of information in which we notice there are some other things that can enhance iron absorption and things that can hinder its absorption. And as you see on the left, the enhancers include things like beta carotene. So those are foods that are very high in beta carotene, red, orange, things like carrots, sweet potatoes, squash, cantaloupes, apricots. Those are all high in beta carotene, and those seem to help with iron absorption when you take those foods throughout the day. And then heme iron itself. So eating non-heme iron foods with heme iron helps to increase your iron absorption as well. So meat, fish, poultry is something that can assist with that. The other is vitamins A and C have been talked about quite a bit. However, those are quite controversial. What we have found is that subsequent studies have not fully supported that either of these alone are great at increasing your iron intake or absorption. However, I guess you probably can go back and speak with your treaters, but the information related to the studies on these, some of them were very brief, and the other is that they never panned out in long-term studies. So beta carotene is good at converting to vitamin A in the body, which may help. And the vitamin C in a long study did not show any difference between those patients who took iron with vitamin C or iron alone. So whether or not you do that is something that you can talk with your care provider about. And then the stomach pH. So the more acidic it is, the better that the absorption of iron is. And maybe that's part of why vitamin C is somewhat helpful. It could potentially change the acidity of your gastric contents if you're taking that. Some of the hinderers or things that block absorption are things like phytates, which we find in whole grains, cereals, soy, nuts, and beans, legumes, peas. Calcium, so milk and dairy products, any calcium supplements, those have shown to show an effect on reducing iron absorption. But again, in some long-term studies, that wasn't always borne out. However, there are some suggestions about how to take iron in relationship to calcium. Polyphenols, which we see in coffee, tea, wine, vegetables, fruits, and again, the bean family, the legumes, those can also affect your iron absorption, as does oxalates, which we can find in chocolate. So unfortunately, that's probably why we're not seeing chocolate-covered iron supplements, but I don't know, maybe we'll change that. And then one of the biggest ones, of course, is antacids, because if you take antacids anywhere near the time when you're going to take an iron tablet, you are going to change the pH of the stomach contents, which then will reduce the absorption of iron. Next slide. So there are some suggestions that we would say from a dietary standpoint. Again, as Dr. Mast said, if you're truly iron deficient, diet alone is not going to replete or replenish your iron stores. But these are some suggestions to help prevent that slide into iron deficiency. So eat a variety of foods, both heme and non-heme, and then they can help, like I said, the heme can help the non-heme iron absorption. Try to drink your tea or your coffee between meals, if possible, not at the same time that you're taking high iron foods. We want you to avoid calcium-rich foods or supplements, especially at the meal where you're having your highest dietary iron intake. We would ask that you avoid any of those hinderers that we talk about, especially antacids, anywhere from 2 hours before to 2 to 4 hours after. And in the studies that I saw, these were after meat meals, which of course meant that you were taking a meat that was rich in iron, also with some form of vegetables. They were talking about salads. And in that study, they also included any food that had a little bit of vitamin C content. And again, controversial enough that that's something to discuss with your care providers. I had one patient who was adding ground liver to her ground beef to help with the process of increasing some of the iron intake that she might have. We suggest that you can also cook in cast iron pots and pans. And we do know that there are some people who prefer to stay more on a dietary side of things as opposed to taking medication. So there are some interesting scenarios in which you could consider using an iron ingot in your cooking. Next. So what I'm talking about specifically is a study that was done in Cambodia by some Canadian health workers back in 2008 and 2009, in which what they did was asked the villagers of a certain area of Cambodia where there was a lot of iron deficiency to try cooking with iron in their foods. And what they did was they finally developed a little thing called a lucky fish. They had tried different formulations of the iron ingot, such as a lotus flower, things like that. But people tended not to do it, and they wouldn't do it when it looked just like a plain lump of iron. But when the researchers asked the elders in the community what might be something that would be good, they talked about this fish in Cambodia that was considered lucky. So they made these iron ingots of lucky fish. And from there, they did this study in which they had the villagers add the iron ingot while they were cooking. And what they found was that over 12 months, it increased the level of blood iron and it decreased the anemia by 43%. The Nambu egg, which you see on the bottom, is essentially a Japanese equivalent, and they have been using this a long time to produce what they call iron water. So what you would do if you wanted to try this approach is, for instance, boil 4 cups of liquid, water, soups, stews, sauces, can be any of those scenarios. It's my understanding when reading the research that you do not impart a metallic taste when you add the ingot or the iron to the pot that you're cooking in. You would then add 2 to 3 drops of a citrus or acidic substance such as tomatoes or lemon juice. And then you would add the iron ingot and boil that for another 10 minutes. Once you're done with that, you remove the iron ingot, clean it and dry it thoroughly, and then apply what they call a protective coating that helps reduce the iron rust formation that happens. So I can tell you that there were instances on the web where people were taking the iron, for instance, the lucky fish, and when they were done, they were putting it to the side, and when they went to do it again, they noticed rust on it, and they thought that the product wasn't working. Well, iron will rust, especially if you've put it into any kind of water, and then you've not dried it off and thoroughly done so. But then adding the protective coating helps as well. It's a little oil that you can apply to it. And the studies suggest that this can provide up to about 75% of the ADA requirement for daily iron. Next slide. So when we need to augment the level of dietary iron, because as Dr. Mast had mentioned, dietary iron supplementation alone is often not enough to counter the effects of iron deficiency anemia, then we talk about iron supplementation from an oral route. And we take into account the acuity of the anemia, how bad the iron deficiency is, the availability of iron products in your area, the tolerance that you might have, and the cost. These are things that we can discuss with you when we go to talk about doing oral iron supplementation. There's a lot of different preparations that are available. We'll talk about those in a minute. But we also want to mention that avoiding enteric-coated and sustained released forms of iron have shown not to be as beneficial, because what happens is the iron gets past the area of the GI system where it's best absorbed, mostly in the duodenum and the jejunum. And these supplements can go past that and not get as much iron absorption. In fact, in some studies, patients were actually passing the pill undigested at all when they were doing the sustained released approach. Dosing and the preparation should be decided by both you, the patient, and us as the healthcare professionals. We should have a good discussion on what you feel might be the approach that's best for you. And that, as Dr. Mast had mentioned, higher and more frequent dosing is not necessary. There have been studies that have shown that you can do as little as every other day dosing in order to achieve iron repletion. And what it does generally is to avoid IV iron needs, which requires, of course, venous access. So people who have poor veins may not want to do IV iron infusions if they can replete their iron with oral stores. There are, of course, monitored infusions that have to occur because IV iron can have side effects, just as oral iron can have side effects. And those infusions can sometimes have reactions up to and including anaphylaxis. Next slide. So the types of oral preparations you'll see here, I listed quite a few, and they give also some of the elemental iron amounts in them. So for instance, you'll see the ferric maltol has 30 milligrams. Things like ferrous sulfate, which seem to be the most common iron forms of oral iron out there. A lot of patients will take that. They can have elemental iron as spread out as anywhere from 15 to 65 milligrams of elemental iron. And each of these preparations has its own ability to cause some of the side effects that we'll talk about. So when you take these supplements, what we might need to do is decide if the one that we start you on is the one that you will continue on if you're having problems. There's also polysaccharide iron complexes that can also be associated with folic acid with or without vitamin B12. There are liquid formulations that occur, and we also have gummy vitamins that have, most of them had ferrous fumarate or other forms of iron in them as well. And just a cursory glance on the internet this morning, I found at least 5 different flavors that are out there from a gummy iron standpoint. And as Dr. Mast had mentioned, it can take up to 3 months to see results from oral iron supplementation. Next slide, please. What are some of the common side effects of oral iron? Well, you'll see it here in the picture, somebody who's really having problems from a GI standpoint. The first one, dark stools, is something that happens because of the fact that there's iron that you're taking. It can have a metallic taste. You can have GI concerns that have been described by Dr. Mast, both constipation or diarrhea, stomach pain, nausea, vomiting. Some people get heartburn. And if you're taking the elixir form, you may have to be careful because that sometimes can stain your teeth. So these are side effects that can be addressed. Next slide, please. So the first one, the dark stools, is actually something that we don't have the ability to counter because that's just the iron that's occurring in the stool when you eliminate the oral iron. And it's actually somewhat of a good sign because it tells us that, in fact, you're taking your iron. Now, your stools should be on the dark side, more greenish than black. If you have any black tarry stool, we would want to know that because it could be a sign that you have blood in the stool as well. So we definitely would want to know about that. As far as constipation is concerned, what we would suggest is getting great hydration. And hydration should be with fluids that are low in caffeine and non-alcoholic. Those actually have a tendency to dehydrate you. We'd want you to get good exercise throughout the day and eat high fiber diet, which you would not want to do at the time that you're taking your oral iron, because remember, fiber can trap iron from being absorbed. And then you can also use over-the-counter stool softeners, things like Miralax and Colase, according to the package insert instructions. Often we may start with a lower dose and then increase depending on the ability to tolerate that dose and whether we feel you need additional supplementation based on whether your labs are changing or not. We can always consider switching to a different preparation or formulation. And again, the iron is best taken on an empty stomach, but you can take it with a small amount of food as well if you're really bothered by the GI component of it. But try to make sure you're avoiding any foods that are hindering the absorption of the iron. And if you're taking the elixir, a couple of suggestions are to rinse your mouth out with water after you've done a dose, or you can add the elixir to a small amount of other liquid and then drink that with a straw to bypass your teeth and help eliminate the staining that can occur with that. Next slide. So what happens if I need iron repletion quickly? My stores are so low, I'm really anemic, lots of things are happening. Well, there are IV considerations that we have. It's a great alternative for those with severe GI side effects as well from the oral formulations. And often it's better for patients who have ongoing or severe blood loss, in patients who have, for instance, HHT, which is hereditary hemorrhagic telangiectasia, or Osler-Weber-Rendu syndrome. Those patients have such bad bleeding that oral iron has never been great at doing full repletion for them. So we often will do IV iron for those patients. Other types of patients are those who may have had gastric surgery because it decreases the ability to absorb iron because of the alteration from the gastric bypass that occurred. Anyone with malabsorption syndromes are better from an IV iron standpoint as opposed to oral iron. And when you're pregnant and in your second or third trimester, if you've got GI issues or we're noticing that your iron levels are low and you're deficient, we would prefer to do IV iron at that time frame, because remember, it takes up to 3 months for oral iron to help with replenishment. And when you're in the second to third trimester, you don't have enough time for that to be the case. Next slide. So what do we think about when we're talking about IV iron infusions? Well, we know that this is a way to rapidly increase your iron stores. It's generally a well-tolerated infusion, and it can be done in as few as 1 to 2 infusions. It may require test dose with the IV iron that's being done. And what we would suggest is that those things be discussed when you are deciding the different types of IV iron that you would like to do. It may reduce blood cell transfusions that are required in some patients who are severely anemic and iron deficient. And the infusion rate, of course, is dependent on how well you're tolerating it. So always your vital signs will be monitored, and you will be asked about infusion reactions while you're getting the infusion. And how quickly we increase the rate is dependent on those pieces. The next thing is that you could require pre-medications depending on if you've had any form of reaction to IV iron in the past. Next slide. So there are a number of different types of IV iron formulations. Most of them are given as IV drips, but you can have some formulations that are given as an IV push over a few minutes as well. You see the ones listed here. I will mention that the low molecular weight iron dextran is the one that sometimes can be given as one big bolus infusion of 1,000 milligrams. There was a counterpart at one time that was a high molecular weight iron dextran that essentially has not been used because that product was having a lot of reaction scenarios with patients who were getting it. So different formulations here, different approaches. The number of times that you might need an infusion could be weekly times 5, all the way down to, like I said, 1 infusion potentially. Next slide. So what are some of the side effects that you might get with IV iron? A couple of them are serious enough that when they are present, we may have to stop the infusion or slow the rate to make sure that these are not ongoing and getting worse over time. So some of them are bloating or swelling of the face, extremities. You can get it in your arms, hands, legs, feet. Dizziness, faintness, lightheadedness, especially when you're getting up after an infusion is done. GI pain. So interestingly enough, IV iron often bypasses the constipation and the diarrhea component of it, but you can get some nausea and cramping with IV iron solutions as well. Rash can sometimes occur. You may get a drop in your blood pressure. And then breathing difficulties and chest pains lead us to think that there may be an anaphylactic reaction that's going on. And that's, of course, more moderate or severe as far as it's concerned to us as treaters. So we always monitor for these things very carefully. Next slide, please. So, of course, if you get treatment reactions, what do we do? Well, I can let you know, be rest assured that all institutions have treatment reaction guidelines that they follow. First and foremost, we would slow the IV infusion as needed, and the MD is notified. From there, we continue, of course, monitoring your vital signs and your oxygen saturation as well, because if you start having any kind of chest pain, wheezing, stridor, that gives us more pause as to whether or not we should be giving you iron supplementation or not. IV steroids may be needed in some of these reactions, and epinephrine, again, in scenarios where there are more moderate to severe reaction symptoms going on. So, of course, if that happens, we can consider alternative preparations versus continuing this route of therapy at all. We can try different formulations, which some patients have found to be better from the standpoint of continuing with IV iron as well. And depending on if you've had even mild reactions before, you may need pre-medication for subsequent infusions. Next slide, please. So in summary, just a few things to mention. We know that IV repletion or the replenishment of your stores can be achieved in a number of ways, and that for attention to the foods and medications that you're taking, please make sure you're noticing whether they can affect iron absorption or not. So remember, antacids and oral iron should not be taken together, for instance. If you have issues with one product, we can always choose another. We don't want you to give up necessarily. Consider all the different options that are available with the healthcare professional. Remember that large and frequent doses, which was very common, especially when I first started in hemophilia care back in the late 90s, we would sometimes have people taking doses 3 times a day, and we found that that's not more effective because of the fact that hepcidin, which is one of the pieces of the iron metabolism, when those stores are covered, then there's adding more iron doesn't increase your ability to absorb more iron. So low and slow may be the effect that we would consider starting with. Cost, time can be important factors on what you decide as your option, whether go with an oral route versus IV route. And of course, always contact us as healthcare professionals if you're having any symptoms or side effects of concern. Thank you so much for today. And next slide, we're open for any questions that you might have.
Wow, what a great session. And I think this is a topic that we do not talk enough about. And that's part of the reason that we, not me, but the organizers put this whole thing together. And thank you, Alan and Jim, for really great talks. The chat was super busy while you guys were all talking. And I think it really represents how hard this topic is for everyone, ranging from what does it mean to be iron deficiency, you know, how much iron is needed. And clearly everyone is getting a wide range of recommendations about what to do about taking their iron. We don't have a lot of time left to chat, but I really want to take sort of, we're probably not going to be able to ask specific questions, but we can pull some themes out of the things that were recurring in the chat. And I think one thing is, you know, we learn a lot from Dr. Mast's experience with blood donors, which probably do have a lot of correlations to what we see in women with bleeding disorders who are having heavy menstrual bleeding. And I think one relevant question is, what about this timing that we have with the bleeding and the iron pills? And so I think what I would like to have some clarity on, Alan, is when were the blood donors told to take their iron pills relative to what you were able to see? Oops, you're muted though. We're not hearing you.
We asked them to take the iron pill at night before they went to bed. And I mean, Jim went through a lot of discussion about how and when and where irons absorb better versus not absorb better. And I think doing it at that time, I think helps a lot. And I think you have better compliance. People are likely to remember they associate it with brushing their teeth and going to bed. It's higher compliance.
So Dr. Mast, when you were talking about starting iron, especially after having just donated blood, so your loss initially, it seemed like the patients did better when they started right away with their oral iron supplementation. And I was looking at a study on heavy menstrual bleeding that suggested that the minute that you're noticing heavy menstrual bleeding is when you should also start your iron. It's like your body is ready to take on absorption at that point because of the fact that it's had this acute loss of blood. Would you say that that's pretty fair?
Yep, that's clearly happening. And it's important for blood donors because blood donors always want to take iron right before they go to donate again because they want to get their iron level up, which doesn't work at all. And what's interesting is your body is recognizing that you've lost blood, and we're not sure how that happens. There might be something in the kidney that's detecting relative hypoxia from acute loss of blood or losing blood, and it's making you absorb more iron to respond to that blood loss. Your body recognizes it. So,
yeah. It sounds like we need to have more science done, and it sounds like not only more lessons from transfusion, but probably lots of lessons in our bleeding disorder community too. And I think a lot of the questions we asked, I'm not sure that we have answers for. So I think I'm just looking to spark a conversation. And so there's a lot of questions about, people seem to be told a variety of things about when to take the iron in addition to what formula. And I know that there's just been a lot of recommendations over the years to take it once a day, to take it 3 times a day, to take it every other day. I'm sure we didn't talk about like what's hepcidin doing. Like we have all of these questions. And so maybe starting with Alan, or what do you say? Because my impression has been it's more important to get the iron in than anything else in a way that people tolerate. But what are your thoughts?
So I think that we're advancing in sort of knowledge about how best to treat iron deficiency. And it used to be just give the patients iron 3 times a day. And I think we're finding that that's not the best way to treat it. It causes bad side effects. The patients don't tolerate it. And also there's data coming out showing that it's not effective. I mean, it is. It's just as effective even to take it less frequently. It's because the same as if you give your body too much iron all at once, it does the opposite. It starts turning off iron absorption. The only way your body controls how much iron it has is by absorption. So your body is very tuned to how much dietary iron absorbed from your GI tract to maintain iron balance in your body. And if you start getting too much, it just turns off iron absorption and you stop absorbing it. So that's why Jim mentioned, so there's even some studies saying you should go every other day because it lets your body recover and then you're ready to absorb iron again. But I want to talk, I just think, especially for teenage girls, there's so many, taking a multiple vitamin with iron is such a simple thing to do. So many people already take multiple vitamins with iron. And if it stops and it helps them develop and mature properly, especially with neurocognitive development, where if it doesn't happen, the results are just catastrophic to families if you have severe mental illness.
I would agree, Dr. Mast. I think from our standpoint, we would suggest the same because the teenage diet is not often great at having lots of iron in the foods that are being eaten. So a multivitamin with iron is just a simple approach for that.
I agree. And there's almost no downside that I can think of and possible upside. So why not do it?
And as the hematologist, you guys, we have like a bathtub thing where we have the spigot, which is the iron in, but we have the drain, which is the iron out, and we need to do both. We need to be better about controlling bleeding in addition to making sure that we don't get iron deficient or that we treat iron deficiency properly. So it's not just iron deficiency, it's a clue that we're not doing a good job with the drain part of the bathtub too. I have a question, Alan, related to several questions in the chat, which is where people aren't necessarily having their blood loss because of heavy menstrual bleeding. So I had sort of 2 related questions, and I think I'll only ask one of them. Is there a risk that's just from being female related to iron? Maybe it's body size, maybe it's androgens versus estrogens, and androgens stimulate red cells differently? Or is this something that's known about? Is it a naive question?
No, it's not naive. What I can say from studies of blood donors, though, is that if we bleed a man a lot by making him donate blood, he becomes just like a woman in regards to his iron status. So we can turn a man into a woman from iron status by blood donation. They're no different. We've looked at these studies. Are there differences between how men and women absorb iron? And there's no differences between men and women. What matters is their iron status, not their gender or sex. So
that's really helpful to know. There were a couple of questions here related to alpha thalassemia, which really wasn't, I think, a question I was expecting to hear. And I wanted to maybe just have, maybe we'll have Alan, you address it. One person with alpha thalassemia was told by their doctor they needed to address their iron status. And then they had some questions about blood donation. But I think, it is something that's common enough, and sort of what else is on the list that might look like iron deficiency as well.
Well, alpha thal will look like iron deficiency, right? It can when you're not iron deficient. And I'm not sure what the question is beyond that.
Oh, okay. Well, I guess I could ask two things. One is, or maybe let me make a comment as a hematologist, and even though I'm not a panelist, is alpha thalassemia doesn't get better with iron treatment if you're not also iron deficient. And the second thing is, but it makes it really hard to tell when you are iron deficient because your blood cells are small and you really need to test your iron. I actually don't know if it's harder to replace iron deficiency or anything else in hemoglobinopathies, like alpha thal, not like sickle cell.
Well, beta thal, they'll get iron overloaded because they have ineffective erythropoiesis in their bone marrow, which also stimulates iron absorption. So they'll be heavy iron absorbers just from ineffective erythropoiesis and become iron overloaded. And
that's
obviously,
a good point. Does it happen in alpha thal trait too? I actually don't know.
I don't think it's as prevalent. There's not as much ineffective erythropoiesis. It's all how it's a much milder disease. I mean, you're the expert more than I am on that. And they would I would just test them for ferritin and then.
Yeah.
Because there are one of the things, independent of anemia, you still need iron. I mean, pica symptoms and neurological development are not dependent on the number of red cells you have. It's dependent on iron doing other things in the body besides hemoglobin synthesis.
Yeah, we're a little bit over time, and I just really want to thank everyone for talking. I think that last point gets to, I had 3 comments that I pulled from the chat. One was fascinating symptomatology, learning about what iron deficiency does to us. Very informative presentations, thank you. And the last one's relevant to that. I wish more doctors understood you can have iron deficiency that needs to be treated even without anemia. And from someone who really had a hard time with it. So I think, thank you both for a really informative and thought-provoking thing. I think I have many more questions than I started with, which is the sign of a great talk. And thank you both so much.
Thanks again, everyone, for attending and having us speak.
Hi, yes, I just want to thank you all so much. So thank you, Jim and Dr. Mast and Dr. Johnsen, for being here and presenting on this topic that has been such a big issue for many of the women that are here. We greatly appreciate it and hope that the work will continue to understand how iron is absorbed and how, just how much we need. So thank you.